right, good evening and welcome to today's webinar. I'm Danae Aber, I'm the Healthcare Innovation Supervisor with Well Ahead. Thanks so much for joining us. As usual, your lines are muted to prevent background noise, but please feel free to enter questions into the Q&A box at any time during the presentation, and we will take care of those as appropriate. Before we jump into today's webinar, I do want to go ahead and announce that our next session, which was originally scheduled for June 3rd, is going to be postponed to the following week on June 10th. But next week, I'll go ahead and I'll update that Zoom link and I'll send out an email reminder about the change. Today's webinar is the 10th in our telemedicine or telehealth and practice webinar series presented by Dr. Ted Hudspeth, and we'll be talking about hardware in telemedicine. The slides and the recording will be available on our website with the recordings of all the other previous sessions, which are listed here at walpen.org/telehealth. And we're working on some pre-recorded sessions, which should be posted there in the very near future. And as a reminder, this series is funded in part by the TxLaw Telehealth Resource Center, which is a HRSA-funded program at Texas Tech University designed to provide technical assistance and resources to telehealth programs in Louisiana and Texas. And Well Ahead serves as the support representative for Louisiana providers. And TxLaw is part of the National Consortium of Telehealth Resource Centers. And with that, I will hand it off to Dr. Hudspeth.
Well, hello there. Welcome to our 10th. I can't believe this is going by, but looking back, this has been a great thing for me. You know, every time that you teach others, you learn a whole bunch of things yourself. So this has been a very introspective journey for me to be able to figure out how did we get to where we are now with our telehealth program. And I'm sure hopeful that all of the things that we've been sharing over the last few months will help you in developing your own program out there to help patients. So we'll start off with asking for any Q&As from any of our previous sessions, if you were with us or had a chance to look at them on the website. Danae, had you gotten any yourself?
I actually did get one via email. Someone had submitted a request for some additional information around e-consults, and particularly if they were, as a primary care provider, they wanted to connect with a specialist to do e-consult. How would they go about that, and what information would they need to provide to that specialist if they're not familiar with e-consult? If the specialist says, okay, well, can I bill for this? What codes do I use? How does e-consult work? What kind of information would they need to know to be able to establish that relationship?
Yeah, first off, you would have to have a real conversation with that specialist to let them know that you would like to start sending them e-consults, you know, through that format. You know, it's a little bit of a technical thing. You have to be able to connect electronically, obviously in a HIPAA compliant manner to be able to do that. And so they would have to know what to expect and what was coming, you know, at them. As far as what you need on your particular information, you know, you would summarize all of the patient's information that has been worked up thus far. Say it was a hyperparathyroidism, you know, you would summarize all of their labs, their complaints, and all of the things that you've done thus far, including imaging, and compile that all into one note. And the actual e-consult that would be submitted would start off with a specific question that you are asking the specialist to answer based on all the information given. And you also have to document that you have obtained verbal consent from the patient to do this, just like when they give consent to see you through an electronic medium, you know, they have to do that. It's the same there. And then you document your billing. It needs to be 15 minutes minimum, you know, total time. Of course, when you're summarizing all of those things for a patient like that, that's generally pretty easy to get when you're compiling all that into one big note to be able to send on. You know, right now that there are not a whole lot of places doing this yet, but I surmise that there will be many, because when you start looking at the efficiencies of it, with patients not having to travel, not having to go and meet a new physician and a new system even. And then the patient is able to stay with the primary care doctor who they know and trust. On the primary care doctor's side, they just need a little support. They may not know some of the nuances of the workup of that hyperparathyroidism, but with a little support, they can do everything just fine. So I would suspect that, I know our institution will probably be reaching out to others to be able to do this type of thing in the future. So, as you're getting ready to do that, reach out to me and I'll let you know where we are in that process, because I'm sure we'd love to be able to do that.
Yeah, and I would like to just add, CMS does cover e-consults, and there's a specific set of codes depending on the time, and if the e-consult is done in writing and verbally, or just in writing and that sort of thing. And we did add that information to our telehealth website. And then Medicaid just put out that effective, I think it was the 15th, so very recently, they just put out that they are now covering e-consults as well. And there's a specific code related to that. And again, that's on our telehealth website. So that's exciting that those services are covered from both of those payers.
For those of you with us right now, if you have any other questions, please submit those in the chat and we'll answer those as we go along. Any others, Danae?
Nothing right now.
All right, good deal. Well, we'll move along. So let's start off with a quote. Everything that can be counted does not necessarily count. Everything that counts cannot necessarily be counted. And this is going to hold true as we go through this presentation. Think back about this, because there are some things, right now we're getting a plethora of information everywhere we go. Our cell phones, our pagers, beepers, I mean, everything, the notifications on our computer. Do we need one more thing to start, beeping at us? Well, that's where we're going, guys. With technology advancing, and people are driving this themselves. Everyone wants to know what their heart rate was at 3 a.m., things like that. So does that really matter if you can count it? Yes, you can count it, but does it matter? So that's where you really have to figure out where you cut through the noise and figure out what really is important to you as a provider, and where does it make sense to really help your patients. So let's look at a little overview here on the things that I will cover. First of all, I'll talk a little bit about the current state of telemedicine hardware, and I'll go through the basic hardware that we actually need to use for telemedicine itself. I'll talk about exam peripherals that patients can use, then the whole subject of remote patient data monitoring and video monitoring, and then wearables, which everybody wants an iWatch, right? Or an Apple Watch. And then medication compliance, or tools that are used to track medication compliance, and then some other tools that I would like to present to you. So let's talk a little bit about the current state of telemedicine hardware. There are really 4 different types of telemedicine. The live video conferencing is really the main thing that I've presented to you over all of these last presentations. It's how do you work with patients one-on-one, like you're seeing them in the office, but doing it through a telemedicine platform and caring for them in real time. Then there's an asynchronous form where a patient can store information and forward that to you, and you asynchronously manage that problem. That's actually, we've been doing that forever with the telephone and a phone note, that we get from a patient. That's a form of asynchronous care. And actually, there is a new form of that called an e-visit. In an e-visit, patients actually put all their symptoms in just like your phone note, and you respond just like you have with a phone note, but it is actually a billable code and usable. And so a lot of folks are actually starting to do e-visits. Now, the third one, and these next ones are some that I'll talk a little bit more about. The remote patient monitoring. That's where you're actually remotely monitoring what's going on with the patient and then managing the patient through some form with that. And the last one is kind of a newer thing called mobile health or M health. Everyone's talking about M health stuff. And really that's where the patient sort of manages themselves with apps and various things like that. So there's not a whole lot of hardware with that. It's more software. So I won't go into great depth with those today. So the current state, as I was saying, we are currently being inundated with all these new gizmos and gadgets with the smartphone apps and the watches, the wearables, the programs, the blood pressure cuffs, the glucometers. I mean, all of these things are really inundating us and really society. So, and patients want to do this now. So that's going to drive all of this. When people want to do it, they're going to buy it. And then we have to deal with it whenever they send us values. And what do we do about this, that, and the other? What I have found, though, in researching this is that a lot of the research is kind of at the early stage. So you're going to have to pick and choose some of these things based on some of the evidence, just like everything else we do in medicine. Show me the dirt, show me the information. And so you really need to be judicious in what you use. And then the actual clinical adoption, this is not widespread yet, but I do believe that the clinical data will come in many of these areas. And today I'm going to actually show you some of them that do have very solid clinical data already. And it's pretty exciting to see some of the numbers, because some of the things, actually the numbers are better than the way that I have done it in my clinic all these years. So let's move on. There was a study that looked at actually providers, I guess, fear or worries about doing all of this kind of stuff. And their fears really centered, number one, around the increased perceived workload. It was just what we were talking about, beeps coming from everywhere. Yeah, we're kind of worried about that. There's a worry about reimbursement. How do you actually get paid for someone checking their blood pressure over time and then sending you the data? How do you get all of that data into your EMR? And when you start asking patients to start doing this, there's a concern about patient motivation, their abilities with technology to actually, get the thing hooked up and get the data to you. And that is driven also by economics. Maybe people cannot afford to get some of these new things. And concerns by patients include security and privacy, and actually accessibility to the tools. Some of them, they're too expensive to afford. And they also fear the impersonalization of care. So, not being right there with the provider like they've always done it. So in that study, I think it was more geared towards the providers than the patients themselves, but there were a lot of concerns. I think those are going to be allayed as the data comes out and shows the efficacy of these things. So the basic hardware that you need right now in your office is a webcam if you're using a desktop. And it's great to have the built-in microphone so you don't have to fumble with a mic. And I recommend looking for one that works in lower light. That's a really good thing. And of course, watch your bandwidth. Some actually come with ratings of being able to work in lower bandwidths, which is good, especially if you're in an area with, not the best of bandwidth to begin with. And then color adjustments and zoom. The thought with this is, when you sit a certain distance from the computer, just to be in the screen just right with, how you're framing yourself, that may not be optimal for your vision, to be able to see the patient or see things on your screen. As a 55-year-old guy now with progressive lenses, this hits home with me, okay? So I actually do have a zoom lens, and I was able to zoom myself in and out. I picked my eye distance first and then zoomed the camera to where I needed it, okay? So that's just a tip. Don't tell anybody, okay? Of course, we all have probably computers and laptops or iPads and things like that in our office. And most all of these can be used if you're getting a new software platform. Most software platforms can go on just about any kind of hardware that you have in stock already. If it's a desktop, you may have to outfit it with a webcam, but most laptops and everything else generally has a webcam already employed. And in much of the literature, they are calling these endpoints. So when you start looking at the literature on these, look for the word endpoint, and that's actually what they're meaning by that. Of course, there are different qualities of networking hardware as far as your router and your modem and things like that. You have to have a minimum of 15 megabits download and 5 upload for a single provider. But if you have several providers in your clinic, you're going to really need to ratchet that up to 50 to 75 if you have several, and if you're a bigger entity, it's going to be 100 at least, because you have to think about other things that come through on your digital lines, besides just you doing a telemedicine visit. And you can look at, there's a link here, speedtest.net. That's a great site to be able to just click on and see what your bandwidth is within your own clinic to determine what your current situation is. And this is a standing desk. Now, this is not a necessity, but man, if you're working long hours doing a lot of telemedicine, you really have to think about telemedicine fatigue. I never really thought about it when I was doing our pilot for our program, because I would do maybe 2 or 3 a day. But when the pandemic hit and I was doing 20 plus visits, sitting at a desk, not moving, staring at one screen for a long time, man, it really set in. So if you do plan on doing a bunch of them, you really need to look at the ergonomics of your space and how you can change that in your day, because it really is more of a necessity if you're going to be doing it for a longer period of time. So let's look at the peripherals. Now, this is getting into what the patients can use to actually help you with your exam. Being able to obtain a blood pressure or a pulse or additional clinical physical findings really extends your abilities on what you can do and care for with that patient through a telemedicine visit. It allows a better exam, and most of the peripherals that are available have a pretty good visual and sound definition to them. And specifically like the stethoscopes, those can be amplified, which is really good. And photographs can be magnified. If they take a really great quality picture, you can really zoom in on that thing like a magnifying glass. And the other thing is these can be shared with consultants. So going back to the first question that we had in the Q&A about an e-consult, imagine you had a patient with a disorder and you were able to send the photos or the audio recording to that e-consultant. What a good thing you've done there to be able to service the patient and the provider in being able to make a decision and then have the patient actually, be cared for through that manner. So having peripherals is, important to be able to do that type of thing, to get into that detail. The big hang up, just like everything else in life, it's money. These can be expensive for people. So we'll start off with stethoscopes. There are many models of them. These two looked really neat to me as far as how they connect and some of the bells and whistles on them. But for instance, this Connect One here, it actually connects in with your laptop, and then that can go through the internet directly to a consultant if you have another person that is doing that. Or you can record the sounds directly to your device, and then that can be transmitted separately afterwards. You can actually increase the sounds of these. So these are actually good for people who are kind of hard of hearing. Providers that need a little help with hearing to begin with, they can help you do your exams, irrespective of being a telemedicine unit. And then there are combination otoscopes, thermometers, tongue depressors, stethoscopes, and cameras. Now, you would think this is like a clinic in a box here. This little TytoCare peripheral, this is one that we actually have at our institution and use. If you look at the little handheld square on the left, that's the main capturing device. And this thing is really neat. It actually Bluetooths to your phone, and guides you through the exam. So for instance, if you put the otoscope adapter on the back side of that, of course, it has a very bright light. And when you position that in your ear, you actually look at your screen on your phone, because it's Bluetoothing to that. And it guides you when it sees the tympanic membrane, the stapes and everything, it actually knows that and self-clicks the photograph button. It clicks the button for you. You can manually do that and then take your pictures of the eardrum. Now, there's a full tutorial on all this for the patients, obviously, to help them know what to do, but it self-guides people in examination, which is pretty phenomenal. Now, those pictures get stored on your device, and then those can be sent directly to the physician, ahead of the visit. And so the patient can do all of this. It takes a little while for them to collect all the data, but that can all be forwarded to the doctor. So you can imagine in those kind of a situation, you could manage that patient potentially visually or through a video visit in real time, or imagine an e-visit. I mean, with e-visits starting now, patients could collect their data, send their question, say, I have a sore throat. Here's the picture using my Tyto device. And then you can see pus on the tonsils and treat them if that's the way you're going to manage them. Okay. So you can imagine how this opens up a whole lot of new doors for patients to be cared for. If you look in the center, that's a stethoscope adapter. Again, it goes on the back there. And patients are guided with a little picture on their phone as to where to place it. They place it there and it records the sounds of the heart in various locations. And then it does the same thing on the back to record the lungs. So you get an auscultation of both of those. And then the thing on the right, that is a tongue depressor, and it does the same thing, recognizes the uvula and snaps the photo, which is really good. Now, the device itself, it has an infrared thermometer on it, so you can obtain a temperature with that. And then it also has a magnifier, so if it's used without any of the peripherals, any of the stethoscope, otoscope, or tongue depressor, patients can just snap a zoomed in photo of a skin lesion. So that's great for skin exams, and then it transmits the pictures with that. So again, as I said, the big problem with these types of things is cost. This one is $300. Okay, so that is out of the reach of many people currently. But imagine if you, say you had a business that you do all of their workman's comp, larger business. Imagine you keeping one of these or placing one of these at that business. And imagine the service that you would be giving that business if you were able to evaluate their workers on site, but virtually, and keep the patients at work or the employees at work. I mean, what a big service that would be. So if you think out of the box, maybe this is a tool that you would position in certain places. What about a school? So that's what people are doing with all of these technologies. They're thinking of creative ways of where can I put this, or where can people use it, and I can service them for their illness. Retinal cameras. Many folks have this now because eye doctors aren't plentiful in rural areas, right? But having this type of a setup allows you to be able to collect your diabetic eye metrics that we all need to do for our value metrics. So I know many regional areas around our parish have these. And for us, we do have one in our clinic. And this is sent to an optometrist that we work with in Baton Rouge. And he reviews all of these and then renders whether the patient has diabetic retinopathy or not. And so this satisfies our metrics for their annual diabetic eye exam. And it's all done virtually. So now we're going to talk a little bit about remote patient data monitoring, not video. This is the data part. And we'll start with blood pressures. Now, for us in our institution, I think around 2013 was when our digital hypertension program started. And at first, when I was looking at the program, I was like, man, I manage blood pressure quite nicely. I don't think we need to worry about doing all of that. And they started the program and they started their study. And in the study, it was pretty phenomenal as far as what they've been able to prove compared to conventional care, as far as getting people to goal and then keeping them at goal. And, most of the programs that I've seen, not only at our own institution, but around the country, these programs are not just check your blood pressure online, have someone look at it and tell you what to do. These are pretty inclusive and above what I do in my clinic. So there are health coaches that are associated with this, that teach people, coach them along on what they should do. There are analytics that are involved with this. So when numbers come in, they actually have an AI program that goes through and sifts through the data. And I understand that there's predictive analytics now on this that can predict when patients are trending the wrong way and can really catch them a little ahead of the time that they would have actually statistically been high. And so they actually get an alert, they intervene at that point and try to turn the tide on the trends that those patients are going in. So this is way above what I do on the one time a patient comes to see me a year, to check their blood pressure. That's way more. The patient's getting a whole lot more value in that. So the home blood pressure cuffs are very accurate. They're pretty inexpensive, and they've been shown to be a better predictor of cardiovascular risks than office measurements. And it's because you're getting so many of them, and it's in their normal habitat, their normal surroundings, and what they are all the time, as opposed to, when they had to fight traffic to get to my office, wait for 30 minutes for me out in the lobby, maybe 15 more in a room before I came in and check their blood pressure. Okay. So you get the drift. That's why they call it white coat syndrome. But they've also shown that the numbers are more reproducible and show more correlation with their actual target organ damage over time, more so than in-office measurements. And the program has been shown to improve medication adherence. Again, this is because of the health coach piece of this. That health coach is reminding people to take their medicines and things like that. And then it's also, they have text features to all of this where it automatically reminds me, and I'm a member of this one. Actually, I have hypertension and I'm in this program. If I haven't checked my blood pressure in a week, I get a little text reminder. It's a happy, gentle reminder. It's time to check your blood pressure. So again, it kind of keeps all of this front of mind for patients as to what they're trying to do. So these blood pressure cuffs, in addition to being part of the program, they also can be used to help me in my telemedicine visits. When I do happen to see them for some other problem, obviously it's great to be able to have them check their blood pressure, and then I can get my metrics for what I'm trying to do with maintaining their blood pressure. And many of these, because they're Bluetooth, they can integrate into an EMR. And of course, you can track their data over time. And that time piece is so important because when you see the trends, that's a very big deal. So I did this on myself. I just wanted to show you how my program works. When I open the app, this picture at the left has a little start button. And again, there's no wires or anything. It's all Bluetooth directly to the blood pressure cuff. I click the big blue start button. Actually, I can choose whether I want it to just check one pressure or three pressures. So I press the blue button, and then you can see it's the little ticker at the left is moving up the line, and you can actually see my pulse waveforms as it's measuring. And then the last is after I got my three pressures. Thankfully, I was below 140, but man, I'm really hitting the button there, really, right? I need to do a little better and get a little lower on my pressure. But all of those are uploaded to my chart. And actually, my doctor can go and look at all of those and see all those values over time. So this is pretty nice. And what I wanted to show you in the actual study that was done on this program, in the digital patients were followed, and they averaged, let's see, 67% of the digital patients versus 32% of the usual care patients had achieved blood pressure control. That was actually at 3 months, okay? And their mean drop in systolic blood pressure was 15 points systolic and 6 points diastolic versus 7 points systolic in the usual care model and 3 points diastolic in the usual care model. So that's really about twice as good compared to the placebo group. And the other piece to this involves the care workers. You see, the digital hypertension program had a 14% better adherence versus a 2% drop in the usual care cohort. So I really think that, again, it's not just the tracking piece. It's somewhat more of all of the other things that you can do in these types of programs to follow patients and get them to do the lifestyle modifications, the adherence to the medications, et cetera, that need to be done. And that's really the main reason that I think there's a better outcome on them. So what has resulted in this, again, when we talked about the doctor's concerns on one of our initial pages, one of the concerns was reimbursement. How do you get paid for this? You know, there's no code for this. Well, in our institution, after this study, they actually have some outcomes data to be able to show some clinical outcomes. And their numbers currently show about a $77 per member per month savings for hypertensive patients that are enrolled in the digital medicine program. Well, that's a real savings to an insurance company. So that's actually the model by which they get paid for digital medicine programs, is they prove the concept, they prove the savings, and then they negotiate the service to be able to provide that to an insurer. So the great thing is that, I mean, I love it when all these things align when you're doing value-based care. Insurers pay less money, the patient has better control, and the doctor is doing a better job. I mean, in all of that, I mean, that's what you call your triple aim there, you know, which is very nice. And this digital hypertension program has proven that. A similar thing has been done with the glucoses. You know, there are digital glucometers now that upload through Bluetooth directly, just like the blood pressure cuff does, directly to your phone, to the app. So this is used to collect not only for these programs, but also you can use this for your own clinics, and many of them integrate into the EMR just the same way as the blood pressure monitor did. And in the digital diabetes program, they showed that from baseline the baseline A1C dropped from 7.5% to 6.8% in just 3 months of doing this program. Again, I really think it's the engagement of patients with the system or the program that really makes the big difference. Here we have something that can really just document, you know, what the trend is over time. And it's something to rally around, to be, you know, checking your sugars and doing something better with their diet and exercise. There was also an improvement in adherence, and there's something called a PAM score. That's a patient activation score, and those scores were actually better with their engagements with doing these programs. So now we'll talk about weight, measuring the weight. Digital scales also can do the same thing as far as tracking patient data over time, integrating with EMRs, and integrating into the digital medicine programs. They can measure weight. This particular one, made by Withings, measures weight, fat composition, and pulse. Actually can do all of that. And this integrates with over 100 apps and EMRs. So actually, I have this particular one myself, and this Bluetooths to my phone. My phone then integrates with my portal. I have a health portal for my provider, my doctor, and I linked those two, through the Apple Health Kit. Those you can link all that data from all these peripherals directly into that Apple Health Kit. Well, from there, most portals will automatically pull data from the Apple Health Kit. Well, for a while, we did not know, but my doctor was getting all my steps. He, every day he was getting my record of my steps because somehow I had my phone hooked to do that. Okay. So he finally told me, turn that off, please. I don't want to look at that anymore. So again, too much data, right? But anyway, so that's the mechanism by which a lot of these things can work and then connect information to their doctor. So there was a study looking at weight loss and doing it through digital monitoring. And a point of this is that this particular study had no face-to-face part with it. So in going through it, they did a dietary replacement. They used self-monitoring with a wireless home scale and frequent guidance via a mobile application. So basically the app was telling them or reminding them in their day things to do or not do, giving them support and that type of thing. And this was a very large study. I believe it was like 250,000 people that were in this study. And they measured mean weight change at 42, 60, 90, and 120 days. The mean age was 37.3 years, and the mean weight loss at 120 days was 5.4 kilos, which when you start looking at some of the drugs on the market for weight loss, that's kind of in line with what you get from some of those very expensive medicines that aren't covered by any insurances. So that was pretty good, I thought. 62% of patients had lost at least 5% of their initial weight. That's pretty massive, I think. So that was a good study and maybe something that could be employed in your own practice. Now, when you're looking at scales, what else can you treat? We all have patients weigh themselves daily on their scales if they have congestive heart failure in an attempt to be able to micromanage that. And there was a meta-analysis that was done of 14 trials, and they did in those show a reduced heart failure related admission by 21% and all-cause mortality by 20%. They, in those, showed reduced costs and improved quality of care and reduced mortality and lower rates of heart failure related deaths, actually. Well, that is actually contradicted by other data out there. So I found there are other studies that contradict the effectiveness of those types of programs. So in my first caution, when we started all of this presentation, you really have to caution some of the data on these. I think that right now we are not where we need to be to say that this is the way that you have to go. I think it's a way to go and to maybe supplement some of the things that you're doing. But in particular with congestive heart failure, I don't think the numbers are quite there yet as far as just relying on that as your main way to maintain and manage patients. Now, one that actually our institution has been very successful with because it's kind of a niche market, but it is really popular. And that is the Connected Mom program. And MOM stands for Maternal Online Monitoring. So what pregnant ladies get is a digital blood pressure cuff and a digital scale and lots of educational materials. And so they start uploading all of their data to their team all during their pregnancy. And three scheduled times, they actually are prompted to go and submit a urinalysis, a urine to check for protein and all that. And in this program, since they're able to collect all this data digitally, they've been able to show that patients actually have 3 less visits on average to the provider, making their care more convenient. So this is something that really has, I guess, sparked a niche market. Like I said, I mean, all moms want to do this now. They want to be tracked and monitored. We have a fairly large GYN group that is actually joining our group because of this program being so popular. They wanted to be part of it. And this is one of their first drivers that drove them to look. So it's a really nice program, and it uses those peripheral tools, and it's all digital. Well, with the pandemic, who hadn't used a pulse ox, right? Having a pulse oximeter has really been a good thing for us to monitor. I know early in the pandemic, it was recognized that lower oxygenation rates were really a big tip-off of folks who weren't going to end up doing well. You know, these, just like those others we talked about, the other peripherals, this will interface with an EMR and upload the data to your phone and be able to be transmitted and be used in the digital medicine programs. But again, going back to the pandemic, that number going down, you know, when those started going down, that's when we started trying to get folks to actually go to the hospital. So they actually started this digital COVID-19 monitoring program. Anybody who tested positive for COVID would get a free pulse oximeter, and they would take that home. And then patients were automatically enrolled in a program where they would get a text daily with a series of questions. And, you know, those questions would allow the patient to put in relevant symptoms, heart rate, oxygen saturation, and their temperatures. And all of this was monitored by a team. Well, when patients' information would, you know, rise to, there was a red flag in any of these, the team would actually reach out to the patient and in real time make a triage decision. And it was those folks who were then sent in to the hospital for evaluation. So the whole goal here was, number one, they wanted to be able to treat patients at home. Most people don't, you know, with COVID don't need to be in a hospital or cluttering up or clogging up the system, so to speak, when they really don't have a medical need to be in the emergency room. At least 80% or more don't have to be seen and can be treated quite easily, you know, just through a phone call and things like that. So with this program, with the pulse oximeter, they were able to sift out those folks, give them and us a way to accurately monitor in real time every day where they were going. And when they rose to the level of need, that's when they would be brought in. So I thought this was just genius by the folks who came up with this program. And it wasn't just us, but I wanted to show you there. This is actually a photo in Britain. They actually used, they called them virtual wards. So patients who were positive, I mean, they were monitoring everyone from a virtual ward. And actually this very tiny thing on the right side that I've left in the PowerPoint so you guys could blow it up and see it. It's actually a workflow of, you know, how do you manage if they have this, that you do that. And so I thought that was very nice. So they use the pulse oximeter in this British virtual ward to be able to monitor them the most or the best. There are digital peak flow meters, and they measure peak expiratory flows and FEV1s, and these are actually covered by Medicare as a DME. So for your asthma patients, this is a very nice thing to be able to monitor when they're going to need additional medications. People who use this do have better asthma control. There have been some pretty good studies looking at that. Of course, just getting people to use peak flow meter to begin with is somewhat of a challenge. But for those folks who do, that the reason we have them is because they work. They do help people avoid the higher dose steroids and the ER visits if they monitor these every day. And all of these go into an app and can upload just like all of the other Bluetooth items that we've talked about. They've actually shown in studies that children who use this have fewer missed days at school, and patients generally report better asthma control and better quality of life overall when they use these. Some of these, and I believe this one that I'm showing here, actually has a pulse ox built into it also, so it's kind of a dual use. And then there are inhalers that have, it's a monitor for when you take your medicine. It measures not only medicine use, but inhalation airflow and the inhaler use itself. The studies show very high patient satisfaction with these. I don't know if that was done by the company or not, but there was a 39% reduction in beta agonist use when they do use this. So that has been shown to actually improve some of the compliance there. 12%, they had 12% increased number of days without symptoms. And they've actually been able to show that's a pretty significant reduction in the beta agonist use because they're using their controller medicines more often and when they are being documented and tracked over time. So let's move on a little bit more to remote patient video monitoring. Now, this is mostly for hospital use, but first of all, there are monitored beds. There's these cameras are very high def. They can zoom, they can move around the room and see everything you can imagine and have very good audio. They have night vision, and this also allows for another consultant to be brought in to see the patient, so to speak, if they're remote. This is something that I experienced personally back in 2017. My father had a stroke and was in the neuro ICU for over a month. And they were frequently rounding on these, actually at a central hub that was actually not even located in our hospital where we were. There was a central hub because they cover ICUs elsewhere, and I'll talk about that in a minute. But this was nice. They would basically come into the room virtually and ask if we needed anything, but they were monitoring all the data on my father at the same time and checking out things. Now, there are areas that use multi-patient monitoring. So this is good for fall prevention, so especially like on telemetry units or elderly units and things like that, and to monitor for clinical deteriorations. Some of these actually interface with AI units or AI software that looks for trends of all of the vitals that are occurring in lab reports and things like that. It compiles all of that together and ahead of time can predict when someone is potentially going to code. So in this scenario with AI, they're actually able to prevent people from codes because they bring in, there's a team, that a rapid response team that is actually able to be brought in earlier than when they just are found to be breathing heavily all of a sudden. It didn't just happen in many cases. People were trending that way. And with AI monitoring, with video and data monitoring, you're actually able to show that you can decrease those kinds of serious event. I was mentioning the EICUs, that's what we were staying in. So think about this, they're actually hubs where the EICU monitors all of the patient's vitals, video, all of their labs and that kind of stuff. And you can have a central intensivist 24/7 where they can watch the ICUs of multiple hospitals in their region. And there are actually 300 plus hospitals now that are doing EICUs. As broadband really expands into the rural areas better, this is going to be something that could help them. Right now, I think a lot of places can't use it because the broadband stinks in a lot of areas right now. So, going back to some of our other presentations, talking about broadband everywhere, we need it desperately so that these types of things can help people who are disadvantaged and don't have all of the resources as close to home as we would like. And through these technologies, we probably will be able to help deliver that better. This is another one that's kind of on the EICU idea. It's called the Telestork program that our institution has. And it's the same thing. You're instead of monitoring your heart, we're monitoring the fetal monitoring of babies as they labor. And they've actually been able to show that they have a decreased C-section rate, reduced frequency and duration of uterine tachysystole, and improved birth outcomes of the babies with decreased NICU admissions. I mean, that's some big data there. And they've improved management of emergency situations such as shoulder dystocia and prolapsed umbilical cords. So again, this is monitored from a central hub, and they help regional OBGYNs manage their practices of laboring units. There's also a telestroke program at our facility, and they currently have 80 partners. You can see the map here, all of the locations where someone in a central location is available using a cart like I have on the right. It's basically a cart, video monitor. They wheel that into the room. And again, we went to our local hospital when my dad had his stroke. We were seen by the local doc, but they wheeled in one of these carts. And at the foot of the bed, the doctor from a remote area examined my father, and the nurse helped with the exam. So the nurse was going through the motions that the doctor was telling her to go through. And once the exam was completed, he made his diagnosis. He also gave the orders to the attending physician in the ER as to what to give. And from there, it was determined that he did qualify and should be transported to New Orleans, which he was helicoptered down there. And so within several hours, we were transported to where he could get the care that he needed. So that's what all of these telestroke programs do. In a hub and spoke kind of model, allows you to be able to help areas where they may not have all the specialists that they need to help care for patients. Now we're going to talk about the wearables. I've got mine right here. Check yours. You got yours. These are now fashion and for fitness and for fun. So talk about I call it the iWatch. That's wrong. It's not the iWatch. It's the Apple Watch. I need to change this. I actually just watched the video, and why didn't they name it the iWatch? That's a long story I won't go into. But this measures your oxygen saturation, your EKG, heart rate, altitude changes, your workout data, your VO2 max, fall detection, sleep time, hand washing time, and ambient noise exposure. That's a lot of things. And all of this is monitored and stored over time. My poor doctor, I said, got my footsteps, all of that, all from the watch. But more importantly to me is between that and the phones that we have, many of these peripherals that I was talking about, actually, this is the hub of where they all go to. So yes, there's hardware peripherals, but they go to a central thing. And this oftentimes is now the thing, either your watch or your phone, where the data goes to. In the case of Fitbit, that's all kind of self-contained there. It measures O2 saturation, temperature, respirations, heart rate, EKG, workout data, sleep time, and REM detection, and stress detection. That I was surprised at that because I've never had a Fitbit, but when I was looking up, there's some kind of an electrostatic measurement that they're able to do. When you sweat, it determines that and gives you a readout on your stress. So I don't know. I did not find a study on that. Okay, guys. So again, you have to question the data that you're being presented, correct? And I'm going to talk a little bit about medication management. I'm going to start with just a simple app. There's one called DoseCast, and you basically, it'll give you some alerts as to when it's time for you to take your pill, records it when you tell it that you recorded, and it encourages you to have some consistency. There is some improvement, maybe with at least reporting the adherence with this, but there's not a whole lot yet saying that people actually adhere a little more. So that the data is still out there on that. Alexa's getting into the game. You can get an Alexa medication scheduler, and she will remind you when it's time to take your next dose. And then you tell Alexa, I took my pill, and then it can actually record that. Some of these apps can actually forward information to a caretaker who may be monitoring what you're doing. So maybe they can be the big bag stick to get after you if you don't take your pill. There are smart pill bottles actually within the cap of this. The cap monitors when you take a pill out of it, and it actually weighs the bottle. And so it can tell when you've taken your medication, and then records all that history. It can give caregiver information, and it actually tells if you're taking a pill more than you should have. And then a smart pill dispenser. This one is really over the top, I think. You can actually sort 90 days of pills in this thing of 10 different medications, and it notifies the patient when it is time and dispenses it in a cup. This one actually works with Alexa. So again, Alexa's getting in on the action with this one and helping people know when to take their medications. And this one also can forward information to the caregivers when they don't take their medication or when they do. This one actually is a monthly fee is how this one is paid for. There are biodigestible sensors. So when you take a pill, there's a biodigestible sensor that messages something that you wear that then sends it to your phone to tell something that you took your pill. It may be, your child, if they're after you to take your medication. There's only one pill right now that uses this. And otherwise, I don't know if this is going to be really a big deal over time. And a few other tools that I'll share with you. There's one called the TouchPoint tablet software. I thought this was really neat because, and I wanted to present it even though it's a software, it works with your hardware. And, we talked about endpoints. You can utilize your own tablet that you have right now and use the TouchPoint software to be able to interface and care for patients through this manner. So a really neat use for this would be if you had a community-based type thing, like say you had a school or some kind of a facility where you needed to see folks periodically, they could connect through there and connect into your EMR. And also like in hospice and palliative care areas, thought this would be nice to be able to service patients who, for a short time have high needs, high angst, and being able to easily communicate with them during those difficult times would probably allay some of their fears and maybe prevent some visits that providers sometimes have to do to help them in their times of need. For bigger entities, there are telemedicine kits now, for instance, like offshore, these types of things, you can send that out there and it has every gizmo all built in, including an EKG monitor to be able to transport information, a laptop and all that kind of stuff. But this is good for really remote areas. And this is the over the top, in my opinion. You've heard of the doc in the box. Well, this is the box, okay? These are areas where it's like a kiosk, and patients can go into these little kiosks and see a provider. Well, the provider's not there. It's done telemedicine, okay? So these could be in a mall, maybe in a pharmacy. Imagine the utility of that, of companies to be able to start, sprouting these up everywhere. Again, what it makes me think of, first of all, is, man, the competition is getting stiff and they're everywhere. People can connect everywhere. And so that does go back to one of our original presentations was, why do you need to do a telemedicine practice? It's because people are going to want to be cared for in as easy and simple a manner as possible. And telemedicine allows you to do it, okay? So I'll close with another quote. True genius resides in the capacity for evaluation of uncertain, hazardous, and conflicting information. Winston Churchill. And I thought that was apropos after I taught you all of the ways that you can collect information that you now have to sift through and figure out what's important and what's not. So I hope that helps some of you in your quest to decide, what am I going to have my patients use? As always, we have lots of resources at the back of every single PowerPoint that we have on the website. And you can always connect with Danae through wellahead@la.gov. The PowerPoints and videos are stored permanently at www.walpen.org/telehealth. And you have my email if you need to connect with me there.
All right, thanks, Dr. Hudspeth. I don't see any questions in the chat. If you guys have any, you can pop them in there real quick. We are right at time. So if I see any come through, I'll let you know, but I'll go ahead and do my little wrap up spiel. So as a reminder, the slides and the recording will be on our website that was just posted, walpen.org/telehealth. Also at the bottom of that page, there's a form where you can submit questions. Those will come to me, or if wellahead@la.gov will also come to me. Any telemedicine questions get forwarded. So feel free to enter questions there if you have some. Our next webinar in the series will actually be in 3 weeks rather than in 2 weeks. So again, we're going to push back that next one. So it'll be 5:30 on Thursday, June 10th, and we'll be talking about telemedicine literature review. So Dr. Hudspeth will do some more, will provide some more information about data and research. And then when you exit the session today, you'll get a survey question in your internet browser. So if you have some topics that you'd like to cover in some future education, please go ahead and enter those there. And as always, please reach out to us at any time with any questions. And thanks and have a great night.